I'm Gay Carlson, President of the American Academy of Child and Adolescent Psychiatry, with another of my SCREENSIDE chats for our AACAP members. SCREENSIDE chats are meant to share timely clinical practice and other information from experts on key topics, inspired mostly by the COVID-19 pandemic now confronting us. I'm hoping they'll be informative and comfortable and fill a niche not addressed by materials otherwise available. My first SCREENSIDE chat was on improvised telepsychiatry. Today's topic may best be described as health promotion and illness prevention done remotely, what child and adolescent psychiatrists can do for patients, families, and healthcare workers. Today's guest will make the point that our skill sets as child and adolescent psychiatrists are now more important than ever and can be deployed remotely and digitally, and will benefit not only our current patients and families, but also ourselves as well as our colleagues battling this pandemic. This is an opportunity for our field to practice aggressive illness prevention and strategies during a time when they're really needed. With me today is Dr. Jim Hudziak from the University of Vermont. And by the way, when Jim talks about remote, he's not talking about Vermont. Jim is an AACAP Distinguished Fellow, Chief of Child and Adolescent Psychiatry at the University of Vermont, where he holds professorships in more departments than I think we have in Stony Brook. Anyway, he holds professorships in psychiatry, medicine, pediatrics, and the communication sciences, as well as having the Thomas M. Hackenbach Endowed Chair of Developmental Psychopathology. Among his other contributions to AACAP are being the former chair for the Health Promotion and Illness Prevention Committee for AACAP and past associate editor of JCAP. He does much more, but this is to tell you about what he does, not what he's accomplished. So Jim developed a family-based health promotion illness prevention model for child psychiatry that he calls the Vermont family-based approach. It's well known. I was actually looking at the website before this because I wanted to know how he got into this business. And it's, Google it, it's not part of my script here, but take a look at the things this man has accomplished at the University of Vermont with his students. It's absolutely amazing. Anyway, it served over 5,000 students at the University of Vermont, turning their heads around from using dope and staying up too late to being really interested in health promotion. So welcome, Jim.
Great to be here, Gay.
We try to develop a script that will be, will answer some of the questions that I think our attendees will want to hear about. And I'm going to start out with asking you this sort of a humane question. How are you guys doing in Vermont? How are you and your colleagues managing with the COVID-19 crisis? How are you doing personally? How are you doing professionally?
Thanks for asking. It's a frightening time for all of us, of course. And in Vermont, we had an advantage in the sense that we were already working on models of how to promote health and prevent illness using a family-based approach. And when the virus hit, or when at least we became aware of it, we literally switched almost overnight to fully remote healthcare delivery using Zoom as our main platform. In fact, in my faculty meeting today with our business team, we've kept all of our visit flows, all of our admissions. In fact, we've had no diminution, and in many instances, families who are facing the stress of COVID, the isolation, the business of having to be together when you don't necessarily like being together has led many of our families to ask for more visits with greater comfort. So on that level, we're good. As a team, we have always practiced self-care and continue to practice self-care. And we've found that we're able to do that digitally and over Zoom in the same way where we used to sit meditations together and walk together. So it's been very nice. Vermont, we avoided the surge. We were buckled down, all of us ready to do everything we could, and our surge never came. And we're starting slowly to reopen our state. And we're all frightened for lack of knowledge of whether or not that's a good idea, particularly for people in my age group and older. But we've been blessed in that way. And so we're going to continue to do the best we can for our patients and families, but also for each other, and then for all the docs that we're blessed to work with.
Well, I'm envious, since in New York, of course, we have the bulk of the nation's sick people. And of course, we're just much more densely populated than Vermont. I have to say I have great pride in how our governor has handled it, and I have a lot of pride in how Stony Brook has handled it. So I think there is some reason for optimism, and that there's some goodness that we're getting out of this in terms of our working together and developing new ways of using the technology we have. Tell me when you became such a passionate advocate for health promotion and illness prevention. When and how, I should say.
It's a great question. I mean, the real secret is using the family as a focus of care. And as you know, because we both share in our biographies training at WashU in St. Louis, and I trained in genetics and neuroimaging. And it became clear to me very early on, from 86 to 93, when I was there, the horrible gang problems in St. Louis, that the environment had a profound effect on the health and well-being of the children that I was asked to see. And I started actually a family-based approach in St. Louis at that time, where I started assessing and treating moms and dads in the service of improving their child's environment, in the service of improving their child's brain development. That was the nidus for the idea. And then in the years that followed with my genetics and neuroimaging research, it was always aimed at this idea, is how important was the environment in influencing the genome, in influencing the brain, and influencing thoughts, actions, and behaviors, which is where all healthcare comes from. And Gay, like most of us in science, I studied bad things for a long time. I studied child abuse and neglect and alcohol and drugs and suicide. And about 15 years ago, I had an epiphany of, instead of studying darkness all the time, because it was wearing me down, if it's true that when bad things happen to a child, bad outcomes will follow, maybe it could be true when good things happen to a child, good outcomes would follow. And that's when I started doing imaging studies of music and exercise, genetic studies of exercise. And lo and behold, it's true. You can build a healthy brain by promoting health. And that was combined to my epidemiology work, where we have to get to the point as a field that all of us have brains, and that all of us are a little bit sad.
I don't know that all of us have brains.
Well, I'm not going to let this go political, but I think psychiatry, and particularly child psychiatry, and I have a wonderful guy at my place, Bill Copeland, who did the Smoky Mountain studies, where it showed 71% of us from birth to age 21 will meet criteria for DSM disorder. 91% by the time we're 30, which led me to believe that the 9% who didn't have a psychiatric problem at some time in their lives were just lying. And it led to this whole idea that all of us are a little bit sad, bad, naughty, quirky, inattentive at one time or another. And perhaps we could work on strategies to develop a healthy brain to diminish our natural vulnerabilities to be sad or anxious. So that took 30 years of a research career, all my papers, my work in the Netherlands and around the world, to arrive at a simple point. The best way to help a child is to help his mom and dad, or whatever the family's defined as, but to help them through promoting health in their lives and then promoting health in their children's lives. So to that end, our prescription paths are filled with the things that neuroscience and genomics says will build a healthy brain in a little kid, in a mom, and in a dad. And it's great fun. It's a great fun to practice child psychiatry like this.
Well, it certainly is a much more uplifting thing to wake up in the morning and dedicate yourself to, and maybe we can diminish the sort of bad things that are happening. I think one of the things I remember you teaching me early on, Jim, was the fact that you take all of your kids off medications and many times put their parents on them. I don't know if you still espouse that, but it's one of the things I remember you saying to me.
Yeah, we probably had a glass of wine when I said that.
Yes, well, I think we probably did. So let's get into it now. How do you think child and adolescent psychiatrists can expand their use of health prevention and illness promotion remotely? And please don't tell me that it requires 100 links, because I don't mind telling you that when people say, oh, here are all these resources, and then I get a screen full of links, I find it kind of off-putting. So what's your approach?
Well, I'm certainly not going to tell you it takes 100 links because I just saw the reaction that it'll foment. But I first want to start just by reaching out to all my colleagues is this idea that this is a golden era for child psychiatry and it's ours to grasp. And I say that because in the same way a cardiologist would never define herself as just taking care of in-stage pump cases in the intensive care unit, but instead she'd say, I design heart-healthy diet programs, exercise programs, etc. I think psychiatry in general made a mistake in child psychiatry a little bit by saying, well, we do owe all of our energies to taking care of people with severe expressions of our disorders. Our genius is really for brains that are not yet traumatized, brains that are not yet ill, brains that are at risk. Our knowledge is for the entire continuum. So let's develop brain healthy diet, brain healthy exercise, brain healthy relationship ideas. That was a driving force. So first, one would be just accepting that the science of medicine would say this is what we should be doing because the brain is the most important organ in the entire body. So you build a healthy brain, a healthy body will follow. And then go to science. And so what we did, and I'm going to switch to a slide for just a second here if you don't mind. What we did is we developed a series of ideas, and this is a center, the Vermont Center for Children, Youth, and Families, which we run. We developed a resource, one link, for all of the patients and all the families we treat. And I would encourage and welcome any of the colleagues that I have in the field, first to use our website, but then go ahead and modify it for your own team members with your own faces. Because part of our idea was even pre-COVID, but now with COVID, we would like the young boys, girls, and children on identity journeys, moms and dads, to actually be able to see the same faces of the same therapist as the same wellness coaches, as the same psychiatrist that they see when they came in. We felt that was wildly important. The next thing we really wanted to do is make it a one-stop shop. And so across the top, and I'll go to this in detail in a little bit, are the major domains of health promotion and illness prevention that we engage in, for which there's wonderful neuroscience or genomic or epidemiology research to prove to you that not only do these things work in emotional behavioral health, but maybe better than some of the treatments that we take as axiomatic of who we are. And for instance, I'll just focus on exercise for a second. Exercise outperforms in any of the kind of domains of psychopharmacology for the vast majority of anxiety, sadness, and oddly, even attention problems over time. And if physicians prescribe exercise 7 days a week, which we very rarely do, we would be stunned by the efficacy, and we have been, and I've published multiple papers on this, you'd be stunned by the efficacy of treating health domains in the same way you would a prescription. And Gabe, by that I mean, we don't usually say to a patient, take this medicine when you want, if you're not too tired, if it's raining outside. We say take it 7 days a week. So one of the things we did is we say you take your wellness prescription 7 days a week, a small dose, start low, go slow. And then we put the medications on our website. And so you can do yoga with our family wellness coaches, meditations with our family wellness coaches. You can take music lessons. We just finished a full guitar lesson set. Now we're moving to ukulele. Andy Rosenfeld, our wonderful clinical director, he leads meditations, provides some screen tips, and so forth. And there's multiple other pages of our entire team here on our website. So I'm going to stop there for a second before we go into the actual prescriptions. But what I'm suggesting to all of us is not a multiple links, but a one-stop shop where people can see the people that they're familiar with. And you're welcome to take our videos. If you want to take our yoga classes, take them. If you want to take our meditations, take them. We'd like to get them as many people as they can. And then listen to their responses. And you'll hear over and over again, you know, I love this. I love doing this. I love doing that. And we prescribe these things for moms and kids, dads and kids. We ask moms to walk with their with their kids, dads to do a meditation with their goth 17-year-old daughter, all the kinds of things that many people might not think was typical of CAP.
Can I also say, full disclosure, when you sent me your page there, I did look at it. And it was one of the most user-friendly ones I've seen. There's not a lot of clutter. There's not a lot of stuff that tells me to go someplace else. The page is sort of divided up into something that everybody can use. And then there are some specific Vermont-based resources that are there. And so when Jim says that you can make it your own, what you can do, since he and his team have done the major thinking, you know, you use the broad strokes, and then you look and see what your resources are in New York or Nevada or California or wherever it is, which your community is, that you can plug them in. So it really is a one-stop shopping event. You've done an outstanding job, Jim. You talk about self-care and burnout abatement for us and for our team members. I think one of the things that everybody has become aware of, and I've been impressed with how, I don't know what it's like in Vermont, because you're not as assaulted by this virus as we are in New York. But when I watch the 11 o'clock news, when I tell you that just about all of the advertising that used to tell me to buy this car and, you know, buy that, whatever, is really devoted to praising our healthcare workers and talking about what heroes they are, and really trying to focus on as much positivity as they can in a dire set of circumstances. Somebody has gotten to the people in the news to let them know that you've got to think that there's got to be some positivity and some, you know, reinforcement to keep people going. So I'm not sure if that's, you know, supposed to prevent burnout, but anyway, tell us some of your other strategies about healthcare promotion and illness prevention in terms of how we help ourselves.
Of course, and what I'd like to do is, sorry, I'm going to try to move ahead on a couple slides. I'd like to first talk about our entire medical center, the University of Vermont Medical Center and the University of Vermont Healthcare Network, because we're all working together. And our healthcare network is massive. It's all of Vermont, it's upstate New York. It reaches into New Hampshire with our colleagues at Dartmouth and elsewhere. And one of the things I'm most proud of is we have something called the VCHIP program, the Vermont Child Health Improvement Program. And what we're currently doing, and again, Gay is going to make all of this available to you guys. But here, our wonderful pediatricians, Wendy Davis, Brina Holmes, the Maternal and Child Health Program, we're working directly with our pediatricians in the community to reach out to them and support them. And this is first and foremost in the idea of helping doctors who are having more problems with their patients around the patient's fear of COVID, infection, morbidity, and mortality. The next thing you want to do, I'm sorry, this is the wrong direction. This is Rob Altoff. I hope many of you know him. If you don't know him, he's now the associate editor of the JCAP. He came out of the Vermont Center for Children, Youth, and Families, but now he's the medical director at our affiliate hospital in upstate New York, in Plattsburgh. And he's an extraordinary human being. And what Rob took on his shoulders, along with others in the network and his colleague, Aaron Stewart, is they put out every single day these moments, these touches, to work with the healthcare nurses, the staff, the faculty members who themselves are anxious and worried. It's beautiful to celebrate and say, we're so appreciative of who you are and what you've done. But the impact of stress and the corticosteroids and the worry and the fear for our own well-being means we also have to bring into their lives BT, CBT, and actological moments, again, delivered remotely. So this is Dr. Altoff's site. It's extraordinary. One of my favorite ones is a little piece he did called Remembering When, which is a focused CBT exercise about remembering when we didn't wear masks everywhere we went, remembering when, and encouraging people that we can remember when in those moments when we struggle most. And I think this is a beautiful point. Our consult service now are open to consulting the physicians in our network. And we're not billing it, we're calling it coaching. And so instead of billing someone for a psychiatric visit, you can do a curbside coaching visit. And it always starts, not always, this is from my colleague Terry Rabinowitz, often starts with, I know a guy, or I have a patient, or I have a friend, in the same way that many of our patient visits used to start. And really what they are is they're talking about themselves and their own fear and their fear of their own mortality. And so we've made our consult teams, our adult and child consult teams, to consult to the practitioners in our field. And then Rob's beautiful programs for the entire healthcare network, not only to say you matter and you're a hero, and they are, but also here's some things you can do to regulate your emotions, to respond to stress. And we think that's wildly important. And that's why we've generated all these prescriptions that are aimed at stress regulation.
So you're going to show us some of you showed us one briefly. You want to show us a couple of other ones?
Sure. But I do also want to talk to you about this atheoretical idea. Okay, you and I came up in these diagnostic, heavy, dogmatic environments of the DSM. And of course, I work with Professor Achenbach on quantitative stuff. But Dr. Guzet once told me many, many years ago that after you've made a diagnosis, it's your responsibility to take care of that patient, given the best of your abilities and skill sets. And for a long time, I've been thinking about N of 1 medicine. And N of 1 is adiagnostic. I don't care if you have schizophrenia, autism, bipolar disorder, anxiety, ADHD. Health promotion is for everyone. And in our center, which is how we treat everyone, is now let's help you deal with the impact of stress in your lives. So I have all my genetics papers show that we all have genetic variability. Now, I've argued that's what makes us beautiful. That's what makes you beautiful in your way, me beautiful in my way, whatever that is. You put a lot of stress on me, my individual variation goes from beauty into pathology. And what we're working on is how do you manage stress and stress reactivity so you can go from dysfunctional to beautiful. And so I'll show you some of the prescriptions because we arm our patients with these things. And the idea is pretty simple. I thought this would move. Yeah, it'll move now for me. We give our families and we write these prescriptions. We put the patient's name and the date. And not only do we tell them what it is that we hope for them, in this case, it's a nutrition prescription, but on the back, we tell them how this will lead to a healthier brain, how the gut-brain axis will help you manage anxiety and depression, improve your memory, regulate your emotions. We do the same thing with physical movement and attention. We talk with really great confidence now because we've published our own papers that daily exercises increases hippocampal size in little 10-year-old kids and improves their mood. And then on the back, we show what happens to their brains, their lungs, etc. So each of these prescriptions and exercise in music from our music papers, yoga, mindfulness and belly breathing, sleep and well-being, positive parenting practices, community connections, reading programs have all come from this wheel of fortune that I call it. And this wheel of good fortune is if we prescribe wellness, we're backed up with not only genomic and neuroscience, but epidemiologic data that says we can have great confidence that this is a better pathway, not a better, excuse me, this is a pathway to helping people improve their health. Now, the nice thing about this is you can do this without having to prescribe a medication. I'm not saying instead of prescribing a medication, but you can do this in addition to everything you're doing, and you can do it remotely.
Do you have difficulty billing for that? I mean, I have to say, you know, as I was looking through this, excuse me, I think a lot of the reasons that we're backed into the corners that we're backed into is because that's what providers pay for.
Yeah, no, 90846, 90847, family care with and without the patients. And no, zero problems. Our family wellness coaches, we've recrafted the names. We honor the training that our people have, but we don't call master's level social workers and mental health counselors those terms. We call them family wellness coaches, and our psychotherapists we call focus family coaches. And we try to debunk and demystify the fact that brain health is anything but ubiquitous. It's what a human being is. We all struggle with variation, so let's coach you up a little bit. And no, they're use the same psychotherapy codes as long as you're licensed and are able to use those codes.
How is your approach being used for kids with oppositional defiant disorder or autism or ADHD or, the usual garden variety issues that children have?
Well, keep in mind, first of all, using a family-based model, you know that from the literature that our great colleagues in psychology here, Rex Forehand and Patterson before him and others, is if we can help parents create a more stable and thoughtful environment through positive parenting programs and other parenting programs, the vast majority of the general psychopathologists, and here I exclude autism spectrum disorder and bipolar disorder, get remarkably better. And if our listeners want to look at the profound effects of exercise and all these other measures in little kids with oppositional defiant disorder, you can see combining improving parent health and using these things in young kids, very powerful. One thing I call them at the very least is a distraction therapy. So every kid who comes to our clinic gets a violin or an instrument and works on violin training. And then I would reflect you to our papers showing, particularly for oppositional defiant disorder, increased cortical organization and the VMPFC, increased emotional regulatory skill sets. So I'd say that for the common psychopathologies, very, very strong. And in fact, we've done a randomized clinical control trial in a general pediatric setting that showed improvements in emotional dysregulation, oppositionality, aggression, and mood. But the thing that we showed that was most remarkable is improvement in the parents' emotional behavioral health and general functioning. And none of these individuals were identified for psychiatric problems. This was done in a well-kid check environment. So it's a very, very kind of exciting time. For those who are most sick, and I would invite our listeners to look at a movie made by a child psychiatrist, Sean Ackerman, called Madness and the Mandolin. It's about a story of a kid who came to my center on 11 medications and couldn't go to school, couldn't go out in public, who's now played bluegrass festivals around the country. I would argue that people with severe and persistent psychiatric illness are the last ones to get the health promotion and illness prevention gems that we're talking about today, and they're the most responsive. And I can tell you via telemedicine, they're the ones I'm having the most fun with because we're playing music together via telemedicine. We're going out on walks together via telemedicine and practicing our health promotion thing, and it's quite joyful. What's good for the brain doesn't matter your diagnosis.
Get down and dirty for me, Jim. Somebody in a traditional setting like mine gets an evaluation from the school about child is having meltdowns and tearing up the classroom, and the school wants to know what kind of program to put him in. How would you apply your program to that child?
Yeah, so first and foremost, we assess the entire family's emotional health and well-being.
We're talking about remotely now.
Yeah, we still do it all remotely. Again, not surprisingly, Gay, we use the ACEBA inventory because I came to Vermont to work with Thomas.
So do we.
Okay, and so what we do is we get these remote profiles, and you see a little kid who's got ADHD and ODD, and you see a mom who's got ADD and a dad who's got ODD. Mm-hmm. We put the kid in a health promotion program where we help mom and dad with their struggles and then help them parent the little dude. And then little dude gets remote music lessons, gets belly breathing exercises with his mom. We put Fitbits on kids. Now I do this with my endowment and mom. And we have mom and the kid walk 7 days a week, and we incentivize them. Papa often gets off the couch and goes walking with his wife and his child because he feels left out. And you can actually see this sort of Hakuna Matata of changing your life, changing your habits, because remember, this is about behavior change, and then seeing outcomes vary. And that's our standard. It doesn't matter if the school's saying he's ODD, she's anxious, he's obsessional, he's quirky.
Did you want to say anything more about, you were telling me beforehand about your VCHIP and VDH, it says, calls. That was what you were talking about before?
Yeah, there are the VCHIP calls and stuff. I was just talking about our responsibilities to work hard with our colleagues in pediatric medicine during this time. People around the country are talking about how we went, and you'll remember this is kind of an interesting phenomenon for many of us, where the call to arms, the psych surge that existed pre-COVID, was children being boarded in every emergency department in the country for psychopathology, and how quickly that psych surge had disappeared. Like, where did they go? Where are all those children? Well, they're in environments where they're not being well cared for. They're provoking parents who may be struggling with emotional behavioral problems themselves, who are not getting help. And so one of the things that we're anticipating, and I think the field of child psychiatry should anticipate in the interims between what almost certainly will be multiple COVID strikes, is there's going to be psych surges as soon as families feel like it's safe to bring their kids to the EDs and stuff. And in fact, I met with my leadership and I said, we've just finished the pulmonary surge, because Vermont had one of the highest death rates in the country for COVID percentage. We're very small, but people were dying here at just a frightening level. We had a pulmonary surge. I went to our leadership and said, we have to get ready for the psychiatry surge, because these kids are not only not coming in, they're staying in environments that themselves have been very, very difficult for mom, dad, and the kid. And talking to the pediatricians with the pediatric medical home, the child medical home, to make sure that they're practicing the same kind of health promotion, illness prevention stuff, but that we're also here for them. We have a 24-hour, well, we don't, it's actually, I don't want to say this, it's 8 to 5 every day, a telephone call hotline. What should I do about this child? What can I do here? What can I do there? Because it no longer seems plausible for them just to send these kids to the emergency department. And even if they do, the parents aren't taking them right now for fear of the child or they themselves getting sick. So part of CAP's job would be, one, anticipating this, what I'm calling the CAP surge, and then secondarily, working with their pediatric colleagues to be partners in anticipating this CAP surge. And that's what VCHIP, Brina, and Dr. Wendy Davis, Judy Shaw, they're incredible at sort of getting on the phone with the pediatricians. Michael Hoffnung, a doc on my team, participates in this as well. And I think it's another place that CAP can play a big role, because the quiet that some places are experiencing right now, it's going to be met with a rebound that I think is going to be pretty staggering. I think.
Yes, yeah, I think we are all anticipating that, and are girding our loins to be able to do something about it. And I'm concerned when the kids go back to school. We don't know how much abuse is going on at this point. I know when I do my evaluations remotely, being able to talk privately to anybody isn't impossible, because everybody's on top of each other. So I've enjoyed what telepsychiatry has taught me, but I have to say I'm mindful of the fact that there are some things you can't do remotely, and one of them is being able to get some privacy with somebody to find out what's happening.
True, but on the other hand, and true, and in fact, one of my fellows and I, Christina Foreman, are right now almost finished with a survey for all the telepsychiatry visits we're doing. how much did you like it? Would you rather see Dr. Hudziak via telepsychiatry than in person, or my entire team? Because there may be a cohort of patients, maybe not having anything to do with diagnosis, but where they live, their socioeconomic status, et cetera, that it's easier for them to see CAPS telepsychiatrically. I have one mom who's just had a horrible life, and I've been taking care of her boy who's now 15 since he was 1, believe it or not. They have more visits now via telepsychiatry than they ever can. They skip, they wouldn't come, there'd be no-shows.
Right.
Now they're overshowing. And then as you say beautifully, there's a whole group of other people that we really need to lay our eyes on, because those special moments where a child, an adolescent can let us know they're not safe, I agree with you. It's very difficult to do by telepsychiatry.
So I think we're going to need to wrap this up. Are there some things that you wanted to say that I neglected to ask you about?
No, just how super happy I am that you're the president of AACAP.
Oh, thank you.
It's pretty cool.
Thank you. I'm super happy that you were able to join me on this SCREENSIDE chat, and I hope that our members will be able to take home some of the points that you told us about, and absolutely take a look at your website and videos, and be able to begin to make it your own, to put into practice some of the things that Dr. Hudziak told us about today. So thank you again, Jim, and good afternoon.
Be safe, everybody.
Thank you all very much for tuning in. This is Gay Carlson for AACAP's SCREENSIDE Chats.